Sure, trials which have been done up to now have largely been population-based, but if you start looking at the data, you find that on a population basis that there is an efficacious response to a particular drug, but within that efficacious response there will be huge variability, with some people responding very well, some people responding moderately, and some people not responding at all. And so that kind of population basis of trials and efficacy data is then extrapolated to clinical practice, where you have an individual patient in front of you that you see in your clinic. And sometimes it's difficult to say whether that drug will work in that patient. In fact, in most cases it's difficult to say, impossible to say at the moment. And so what we need to do, and this is happening in many other areas, is start thinking about ways of stratifying therapies, individualizing therapies, so that every patient that is sitting in front of you in your clinic gets the best therapy with maximal efficacy, minimal toxicity. And so we do need these population-based trials, but we also now need very much stratified trials, which allow us to be able to develop much better methodologies for individualizing therapies. So for clinical therapy at the moment, and in terms of physicians, I'm a physician, we've been personalizing for many years. You know, when somebody comes to my hypertension clinic, I don't give them the same drug. I would look at their age, I would look at whether they've got diabetes, renal impairment, etc., and then I will individualize therapy. But when I do individualize that therapy, I can't predict whether that patient will respond first time to the drug I give them, and so I'll monitor their blood pressure, so there's some kind of individualization going on in terms of monitoring blood pressure, and then I will then either change the therapy or I'll add another drug to that, so that I try to control the blood pressure. So this trial and error approach that we do is a degree of personalization, which is relatively crude. Just imagine if you had a test which actually took you from a degree of empiricism to a degree of predictability, whereby you could actually say, here's a test which will actually almost, not 100%, will never have a 100% predictive test, but increases the likelihood of you responding first time to the first drug you get as a patient. So there's been a lot of work in the cardiovascular area, as there has been in many other fields. Unfortunately, most of the work has really not produced any results which have gone into clinical practice. There's often contradictory data, there is different kinds of genetic factors which have been looked at. And so overall, the literature is pretty confusing out there, and most of it is related to the fact that the studies have been small, the patient selection has been varied and sometimes biased, most have been retrospective studies, and the genetic strategy has not been adequate. However, this is now beginning to change, and there are two drugs out there, which is warfarin and clopidogrel, where there is an enormous amount of evidence accumulating on the role of genetic factors in determining variability in response. Certainly, there are trials now going on to see whether you can use these genetic factors to be able to individualize warfarin therapy, and I know there are trials which are in the planning stage for clopidogrel as well. But as we move forward, and there's a lot of activity out there in the anticoagulant and antithrombotic fields, we need to be able to see how we can use the old drugs such as warfarin using personalization methods, and then stratify them with the use of new drugs as well. The new drugs are important, but do they need to be used in every patient? Do they need to be taken up wholesale, and warfarin and clopidogrel assigned to the yesteryear? What we need to now think about is how we can incorporate the old drugs as well as the new drugs for maximum clinical effectiveness, but also cost effectiveness as well. So the public is very interested in personalized medicine, and certainly in many parts of the world there have been stories in the papers and also television programs about personalized medicine. There is an appreciation that we do need to improve the way we use drugs and to be able to maximize effectiveness, but there's also a lot of misconception as to what we can actually do. And I think what we have to do is to provide a realistic picture. A lot of people hype up the area of personalized medicine, which is not very good for patients, it's not very good for the clinical community and scientific community that works in the area. It is important to give a realistic picture that there are opportunities here for us to be able to optimize therapies, but there are also many challenges to overcome to be able to achieve that goal of optimizing therapies. And so we really need to have a realistic picture and develop the evidence base, and then educate the clinicians but also the public as to what to expect. There is no test that is going to be 100% effective. But what we can do at the moment, from the low predictability that we have in terms of clinical practice that we have to the better predictability, will be through the use of these kind of personalized approaches, is going to be an advance. And in a way, I think the way I do a lot of speaking to the public and in terms of face-to-face, but also in lectures, I always say that what we're doing with regard to personalized medicine is very much an evolution in the way we practice medicine. Medicine advances in small stages. And personalizing therapies by using new genetic technologies and so on is just an advancement in medicine, and it is an evolution in the way we practice medicine.